Hello and welcome back to Beyond Sound. You're tuned into episode 3 of our series exploring the innovations shaping the future of hearing restoration. If you missed our previous episodes, Beyond Sound is brought to you by the Hearing Group, a global network of leading hearing centers working together to advance research, share expertise, and improve outcomes for people living with hearing loss. Now make yourself comfy, because it's time to tune into a very special lecture by Professor Gunesh Rajan, a leading expert in ear, nose, and throat surgery and co-chief physician at the ENT Clinic Luzern in Switzerland. In this session, Professor Rajan explores the fascinating topic of structure preservation. He explains how this field has evolved from simply restoring hearing to also protecting the delicate inner ear and preserving any natural hearing patients may still have. A key idea he introduces is the two-hit concept of inner ear injury. The first hit happening during surgery and the second caused by inflammation afterward. He walks us through careful surgical techniques like slower electrode insertion, controlling inner ear pressure, and he also talks about different electrode designs and drug-eluting electrodes. His lecture will be followed by a discussion involving world-renowned experts such as Professor Hagen, Professor Dillon, Professor van der Heyning, Associate Professor Weiss, and Professor Gavilan. The discussion will even look into robotic insertion systems and debate whether longer electrodes can be just as safe as the short ones. If you're not driving at the moment, you might take advantage of the complimentary slides in the video to make your learning as wholesome as possible. And now, settle in, and here we go!
And we are here to introduce you to Professor Gunesh Rajan. Gunesh is a good friend and a specialist in otorhinolaryngology as well as neck and face surgery. He worked as the professor of otolaryngology, head and neck surgery at the Medical School of the University of Western Australia in Perth. But now he turned upside down, you can see him down upside, and is the co-chief physician at the ENT Clinic Luzern in Switzerland. Hearing is delighted to have him as one of our prominent members, and he will start dealing with the topic of preserving the intracochlear structures, structure preservation. Gunesh?
Thank you very much, Javier. Thanks, Baumi, for the introduction, dear hearing group, dear participants. It's a great honor to be again part of a round table. And as you already heard, we have quite an exciting topic today, and I'll try and breeze through the sort of super concentrated infos regarding how to do a surgery in order to preserve the structures in the cochlea, because that's essential for everything what comes afterwards, what happens afterwards with the cochlear implant. I would like to acknowledge a great group of people from the research group in Perth. Over the last 15 years, we're able to do this phenomenal work I'll be talking and reporting about. So I think it's quite interesting that, cochlear implantation initially was purely for restoring hearing in deaf people. And over the last decades, it has evolved to not only preserving or restoring hearing, but actually also expanding the indication for patients who have some amount of residual hearing. So and there the foray of electric acoustic stimulation came up, combining the hearing in the implanted ear and combining it with the electric hearing of the implant, which gave a lot of benefits to the patients. And then from there on, we realized, that it's not only hearing preservation, the inner ear is much more. It's also the vestibular system. So we realized, well, we had to preserve the inner ear in total, and thus the term structure preservation arose, because not only the hair cells, but also the bony structures, especially the neural structures, So that evolved, and it was quite a fascinating journey. So how do we prevent damage to the intracochlear structures during cochlear implantation? You can see this beautiful image from our good friends, Professor Agrawal from London, Ontario, where you see how the electrode goes into the cochlea, into the scalar tympani, and if we want it to be there and cause least damage. And I think the key elements, and I'll just touch a few of them because they'll be quite a few will be part of the topic, is the patient factors, especially the anatomy and the genetics and the residual hearing. I'll touch briefly on the inner ear protection through pharmacologic agents. We'll talk about insertion mechanics, there a little bit about electrode array design. I will not talk about the intraoperative hearing monitoring because that's a big topic on its own. So I think it's really important for us, for me to conceptualize what's happening with the inner ear during cochlear implantation. I think a good concept is this two-hit concept of inner ear injury during cochlear implantation. So the first hit, the first trauma occurs during surgery, right? And then once that surgery is done, the electrode array is in, everything's good, the second hit follows. The second hit consists of all these various processes, mainly of inflammatory nature, which can have an impact on the inner ear health. And that can be days, months or weeks after cochlear implantation. So, and I think if we understand these two hits, we can sort of tailor our activities, the surgery and what happens afterwards in order to minimize these hits. So I'll briefly go through, the current concepts of how to tackle the first hit. So the first hit occurs during the cochlear implantation, when we as cochlear implant surgeons insert the electrode array. And a lot of this is about insertion mechanics, what happens inside the cochlea. So I think a lot of it is related to the changes of intracochlear pressures. So the first thing is, how do we open the round window? Already there we know pressures can occur in the cochlea, so we know how to attenuate that. We do it underwater. The role of insertion speed, I think now that's universally accepted that the slower you insert, the better it is to preserve the intracochlear structures. The other little detail that's important is, I just want to mention that it's quite important to rest the hand with which you're inserting the electrode. Because as you can see on this slide, the black line shows a surgeon that rests his insertion hand, and the other two are surgeons that basically have freehand insertions. And you can see the variations in the intracochlear pressures is much higher if you do not rest the insertion hand. The array design is important. In your top left, you can see the intracochlear pressure rise in the perimodal arrays. On your right-hand lower corner, you can see the effects of the smallest lateral wall electrode on the intracochlear pressure change. So you can see there's quite a big difference, which is translated into the cochlea, a level is huge. After inserting the electrode, I have to point out the work's not done regarding preventing injury, because we know if you move the lead during the post-insertion, when you put the lead into the mastoid bowl, you can cause, as you can see on your left-hand side, you can cause a lot of pressure change. But that can be easily attenuated again if you fix the lead or hold the electrode and then place the coil into the mastoid bowl. And then how do we tackle the second hit? Remember, it's the processes that cause the inflammation after the implantation. And there, of course, pharmacology is quite useful. And the easiest pharmacologic agent we have are steroids, glucocorticoids. So they are, at the moment, probably the most available unit, a drug which can protect or help minimize these inflammatory processes. And this is just a slide to demonstrate what happens is if you add on the top row, you add dexamethasone, and the lower lines of images is the control. And what you can see is, if you look at the right-hand side with the implanted ear, you can see in the guinea pig model, you can see that how well not only the hair cell structures are preserved, but also the neural structures, the spiral ganglions. So yeah, this is sort of in a super concentration, the effects or the techniques on how to try and minimize intracochlear injury.
Well, thank you very much, Gunesh. It's been a very clear presentation, and it's a concise presentation, and so we have time for discussion. Now, my first question will be, you mentioned that perimodiolar injury is bigger than the one from a straight electrode. A long straight electrode is more dangerous, makes more harm to the cochlea than a short straight electrode or than a perimodiolar electrode?
Well, there's sort of various dimensions. It's a good question. I think, especially if you look at the speed, it really doesn't matter how long the electrode is when you look at the intracochlear pressure changes. But I think the main issue is with the perimodiolar electrodes, the risk of tip fold over, which causes significant disruption, also pressure-wise, force-wise. And that's why, and that's also reflected. I showed one slide where, comparing the different array types with regard to the rise of the intracochlear pressure as the electrode goes in, and clearly there, the perimodiolar arrays have a much steeper increase in that pressure.
Good. Do you all agree? I mean, Meg, do you agree that a long straight electrode is not dangerous?
So we've seen some compelling evidence of hearing preservation with the longer electrode arrays, the 31.5 millimeter electrode array. So I think the impression that if you put in a long array, you're going to sacrifice the acoustic hearing or damage the structures is something we're learning a lot more about, that we no longer think that is as high of a risk as it was before, and now think more about what are those acoustic thresholds and whether it's better to put in a long array in case they lose hearing so that you can provide stimulation in that apical region. And I know some of the other panelists will get to that later, as opposed to putting in a shorter electrode array. So a lot to be learned, but feeling more optimistic about it these days.
Okay, we have a question from the audience. My good friend, Professor Hagen, wants to ask you something. Go ahead, Rudolf.
Okay, during the last ESPCI meeting in Rotterdam, Thomas Lennertz from Hanover presented his results, remarkable results with the dexamethasone-eluting electrode. Maybe you heard about this. So with very low impedance levels for at least 9 months, and also with a higher hearing preservation rate. What's your opinion on this, Gunesh?
Thank you for the question, Rudolf. Great point. I mean, the drug-eluting electrodes is a beautiful example how to tackle the second hit effectively. So all these processes that are occurring after the array insertion, in the days, weeks, and months coming, it looks like with the drug-eluting electrodes, you can attenuate these effects. And that's great, because while the impedances, the impedances are like a surrogate marker for the intracochlear fibrosis, we assume nowadays, right? And the fact that with these electrodes, drug-eluting electrodes, the impedances are staying low is a surrogate, basically indirect sign that obviously all these fibrosis inside the cochlea is being reduced or minimized, which is great, which is what we want. Yeah.
Good. I like your Gunesh. I like your slide about the resting hand. But I mean, for surgeons to introduce the electrode, even if your hand is resting, it's a very difficult thing just to keep always the same pressure and the same speed. So why don't we develop a robot? I mean, we are working on robots for just reaching the round window, but I think we need the robot just to insert the electrode. This can be done by a machine easily or not. It's a utopia.
Well, I think the tools are already here nowadays. You know, there's various devices, insertion devices. There's companies that are focusing on this. They are actually, you know, their portfolio is an insertion device for electrodes, right? And I think now it's on us to really use these devices and see what the benefits are, because they're all mechanical devices, and obviously they can certainly, as you said, they are far superior when it comes to the insertion and the speed and the amplitudes and the tremor elimination. They are all way superior to the manual insertion. But I guess time will tell which of these various devices now available are really successful and feasible as well in theater.
Okay, Paul, what's your opinion about the long electrodes and hearing preservation, just structure preservation, not hearing preservation? Paul, you're muted.
Yeah, okay. Well, we did a literature review comparing the different lengths of the flex electrodes. I have to insist, it's our lateral wall, very flexible electrodes. And when we did this literature review, there was hardly a difference between the different lengths of electrodes. So more important is the use of the corticosteroids, the very, very slow insertion, and the non-atraumatic way of doing cochlear implantation. But the length on itself, initially, were documents, or we thought that long electrodes were more detrimental to the inner ear, but this literature review turned out that is not the case. So in choosing electrode lengths, this is not a main issue anymore, just like Margaret said.
And that wraps up this episode of Beyond Sound, where innovation, precision, and experience come together to advance the future of hearing restoration. A special thank you to Professor Gunesh Rajan for his insightful lecture on structure preservation and cochlear implantation. And of course to our distinguished panel of experts, Professor Hagen, Professor Dillon, Professor van de Heyning, Associate Professor Weiss, and Professor Gavilan for their thought-provoking discussion. It's inspiring to hear how careful surgical techniques, evolving electrode designs, and new technologies like robotic insertion systems are helping to protect the inner ear and preserve natural hearing, while continuously improving patient outcomes. If today's session sparked your curiosity, be sure to visit boost.hearing.com, where you'll find more masterclasses, symposia, and expert-led courses from the Hearing Group. Don't forget to subscribe to Beyond Sound on Spotify or YouTube, and connect with our community on LinkedIn, Instagram, YouTube, and Facebook. Just look for @Hearing Group. Thank you for tuning in today and for continuing to go beyond sound with us. So until next time, keep listening, keep learning, and keep pushing the boundaries of what's possible in hearing care.